Welcome back to the deep dive. Today we're doing something a little different. We aren't just skimming the surface of a topic, we are literally going into the mud.
Yeah, right into the swamp.
Exactly. We're wading into fresh water to look at a group of organisms that have arguably the most complex and deceptive and honestly evolutionarily brilliant life cycles in all of biology. We are talking about trematodes.
The flukes.
The flukes. And I was thinking about that name this morning because in English, a fluke is a lucky accident, right? Like a 1 in a million shot. I hit that basket by a fluke.
Right, yeah.
But when you actually read through Murray's chapter 75, which is our main Bible for today, you realize there's absolutely nothing accidental about these things. Their life cycle is precision engineering.
It really is. It's a biological Rube Goldberg machine.
Mhm.
If any one of like 4 or 5 incredibly specific steps fails, the organism dies.
Yeah.
And yet Schistosomiasis alone affects over 200 million people worldwide.
Yeah.
So despite the insanity of their complexity, they're winning the evolutionary game.
They really are. And for everyone listening, whether you're a med student prepping for boards or a resident or just someone who wants to understand how parasites manipulate hosts, we are going to break this down systematically.
We're using Murray as the primary spine for this deep dive, but we'll sprinkle in some context from Jaywitz where it helps clarify the epidemiology.
Right. And the goal here is to build a mental model for you. We don't want you to just memorize snailfish liver. We want you to understand the why.
Exactly. The why is everything. Why do they migrate the way they do? Why does the immune system react with granulomas? If you understand the mechanism, you don't have to memorize the clinical presentation.
You can just predict it.
You can predict it exactly.
So let's start with the fluke blueprint. If I'm looking at a trematode under a microscope, what am I actually seeing? Because they look kind of prehistoric.
They do look prehistoric. The classic visual anchor you want to keep in mind is a leaf. Imagine a thick, fleshy leaf. They are flatworms.
Yeah.
Platyhelminthes, so they aren't round like the nematodes.
Yeah.
And they aren't segmented ribbons like tapeworms.
Right. They're dorsiventrally flattened, fleshy ovals.
Yep. And the name trematode comes from the Greek for whole, right?
Yeah. Trima means whole, which refers to the suckers.
Right. Almost all of them have 2 muscular suckers. There's the oral sucker at the anterior end, the front, which is basically the intake valve, and then there's a ventral sucker, sometimes called the acetabulum, right on the belly.
And this is a key physiological point that stuck out to me. The ventral sucker is just a holdfast. It's a grappling hook. It doesn't actually eat.
Its only job is to fight peristalsis. I mean, if you're living in a gut or a bile duct where things are constantly flowing out, you need to anchor yourself. That's what the ventral sucker does.
Now let's talk about the digestive system, because this honestly blew my mind when I first learned it. They have an incomplete digestive tract.
That's a very polite way of saying they have a mouth but no anus.
Which seems like a major design flaw.
It's definitely primitive. The esophagus just splits into 2 blind-ended intestinal ceca. So they ingest blood or tissue, they digest it, and then the waste products, well, they have to come back out the exact same way they went in.
They regurgitate their waste.
Yeah.
And biologically, this is huge, right? Because regurgitating your waste directly into the host's bloodstream or tissue is a massive immunological trigger.
It is a huge trigger. A lot of the pathology we see isn't just from the worm biting. It's the host's immune system reacting to this constant stream of regurgitated antigenic waste.
I also want to touch on the tegument. We tend to think of skin as just a wrapper, but for a fluke, the skin is actually a metabolic organ.
That is a great point. The tegument is syncytial, meaning it's a continuous layer of cytoplasm without cell boundaries. And it's metabolically active. It absorbs sugars and amino acids directly from the host fluids.
Wow.
Plus, it has to defend the worm. Remember, the liver flukes are living in bile. And bile is a detergent designed to break down fats. The tegument has to be incredibly robust to stop the worm from just being digested by the host.
So it's like this armored eating skin.
Exactly.
Okay, so reproduction. Murray makes a really big deal about this differentiator. Most flukes are hermaphroditic.
Correct. Fasciola, Clonorchis, paragonimus, they all contain both male and female reproductive organs in the same body. They can cross-fertilize with another worm, or they can self-fertilize if they're alone.
It's an insurance policy.
Right. If you're the only worm that actually made it into the liver, you can still reproduce.
But then we have the rule breakers, the punks of the trematode world.
They're schistosomes.
Yeah.
The blood flukes. They break pretty much every rule. They have separate sexes. There's a male and a female. And the sexual dimorphism is fascinating. The male is shorter and stouter, And he has this groove running down his body called the gynecophral canal.
The canal for the bearer of women.
Literally, yeah. The long, slender female lives inside this groove. They are essentially hugging for their entire adult lives, just drifting through your blood vessels.
It's surprisingly romantic for a parasitic infection.
I mean, until you realize they're churning out thousands of eggs a day that are completely destroying your liver.
Yeah, fair point. Speaking of eggs, that's the other major structural difference, right? The operculum.
Yes, this is super high yield for lab diagnosis. If you see an egg with a little lid on top like a trapdoor that is an operculum, all the hermaphroditic flukes, so liver, lung, and intestinal, have operculated eggs.
And the schistosomes?
No lid. They
No.
just split open. So if you're looking at a micrograph on an exam lid equals general fluke, no lid equals schistosome.
Okay, so we've got the morphology. Leaf-shaped, blind, gut-armored skin hermaphrodites with lidded eggs, unless you're a schistosome. Now, before we get into the human body, we really have to talk about the snail imperative. This is the core of the whole life cycle.
If you take nothing else away from general trematode biology today, take this: no snail, no fluke. Every single trematode we discussed today requires a specific species of freshwater snail as its first intermediate host.
And it's not just a taxi ride. The snail is a cloning factory.
That's the best way to describe it. It's biological amplification. Let's trace it. The egg hits the freshwater, the lid opens or the shell splits. Out comes a miracidium. This is a ciliated swimming larva.
It's like a tiny submarine with a...
With a sensor array. Yeah,
Yeah.
exactly. It has about 6 to 8 hours to find the specific snail. If it fails, it dies.
high-stakes hide-and-seek.
Extremely.
Oh.
But if it penetrates the snail, it sheds its cilia and transforms. It becomes a sporocyst, then it produces radii, and inside these forms, asexual reproduction happens. Germinal cells are dividing like crazy.
So one single miracidium entering a snail can produce thousands of the next stage.
Thousands of cercariae, yes.
It's basically polyembryony. One embryo becomes thousands, which makes perfect sense evolutionarily because the chances of finding a human host are incredibly slim, so you need to just flood the zone.
Exactly. The snail sheds these cercariae, which are little swimming missiles with tails, into the water, and this is the fork in the road for the life cycle.
Right, path A versus path B.
Path A is the standard route taken by the liver, lung, and intestinal flukes. The cercaria finds a second intermediate host, a fish, a crab, a water chestnut. It burrows in, drops its tail, and forms a cyst called a metacercaria.
And this cyst is tough.
Very tough. It can survive stomach acid.
Yep.
It just sits there and waits for a human to eat the host.
So path A is foodborne, ingestion.
Path A is ingestion. Now, path B is the schistosomes. The rule breakers, again, they don't have patience. The schistosome cercaria swim directly for the human. They literally sense the lipids on your skin.
Wow.
Yeah, they release enzymes, bore through intact skin, and enter the bloodstream directly.
Direct penetration, no eating required. That is the fundamental split you have to remember.
All right, so now we have our mental map. Egg touches water, snail amplification, cercaria leaves snail, and then either insist in food for path A or drill directly into skin for path B.
Perfect. Now let's apply this model to the human body. We're going to go site by site following Murray's structure. Intestine, liver, lung, and then blood. Let's start in the gut. Section 1, the intestinal fluke. Fasciolopsis busci.
This is often called the giant intestinal fluke, and the name fits. Fasciolopsis is huge. It can be up to 3 centimeters long.
Which for a parasite is enormous.
Mm.
That's like a small lime wedge just living in your duodenum.
Exactly. It's fleshy and red. You can see it with the naked eye easily.
Yeah.
Geography-wise, we're looking at China, Vietnam, Thailand, parts of India.
And the transmission narrative here is really specific. It involves pigs and water plants.
Yes. Pigs are actually the major reservoir host.
Yeah.
The transmission usually happens via aquatic vegetation, water chestnuts, bamboo water caltrops.
So here's the classic scenario, right? You're in an endemic area. You harvest water chestnuts from a pond where pigs have been defecating. The metacercaria, the cysts, are stuck to the husk of the chestnut.
Right.
And you don't have a knife, so you use your teeth to peel the husk off the chestnut.
And pop, you just swallowed the cyst.
You swallow the cyst. It survives the stomach, enters the duodenemic cyst, and attaches right to the intestinal wall.
Now, in terms of pathology, Murray differentiates between a light infection and a heavy infection. And you might wonder why that matters.
Right.
It matters because a single worm, or even a few, might just cause some local inflammation, maybe some mild indigestion. But remember, these are big worms. If you have a heavy burden, hundreds of worms, you get 2 major problems.
Mechanical damage and obstruction.
Exactly. First, mechanical damage. They're actively biting the mucosa, causing deep ulceration, hemorrhage, and abscesses at the attachment sites. And second, physical obstruction. They can literally block the intestine just by their sheer volume.
So you get diarrhea, abdominal pain that totally mimics a peptic ulcer, and potentially severe malabsorption because the gut lining is so inflamed.
Precisely. And in severe cases, you get generalized edema and ascites, which is likely due to protein loss from the gut, a protein-losing enteropathy in the systemic absorption of worm toxins.
Okay, let's talk diagnosis. We're looking for eggs in the stool.
And here's the exam trap. This is crucial for you to remember. The egg of Fasciolopsis busci is large, golden, bile-stained, and operculated. But it looks absolutely identical to the egg of Fasciola hepatica, the sheep liver fluke.
Wait, so you cannot tell them apart under a microscope?
Not reliably, no.
Yeah.
So if you get a question with a picture of a large, golden, operculated egg, you have to look closely at the clinical vignette.
The context.
The context, exactly. Is there liver involvement? Jaundice. Right upper quadrant pain? That's fasciola. Is it purely intestinal, diarrhea, epigastric pain? That's fasciolopsis. Also look at the exposure history. Water chestnuts point to fasciolopsis. Watercress points to fasciola.
That is such a great differential key. Okay, what about treatment?
Praziquantel. It's the broad-spectrum anti-trematode drug. It works by increasing membrane permeability to calcium, causing the worm to contract continuously, causes spastic paralysis. They let go of the gut wall and they're just flushed out.
Easy enough. So Fasciolopsis, the giant pigs, water chestnuts peeling with teeth, and an identical egg to Fasciola. Let's move upstream. Section 2, the liver flukes. This is basically a tale of two worms, Fasciola hepatica and Clonorchis sinensis. They both end up in the bile ducts, but they take very different paths to get there.
This is actually my favorite comparison because it perfectly illustrates how diverse these life cycles can be. Let's start with Fasciola hepatica, the sheep liver fluke.
This is a cosmopolitan parasite, right? Found worldwide wherever sheep are raised.
Right. Sheep and cattle are the natural hosts. Humans are just accidental hosts here. The transmission vehicle is, again, aquatic plants. Watercress is the classic board exam association.
Right, so I eat the wild watercress salad, I swallow the cyst. Now, you've described this migration as violent. Why is that?
Because most parasites are polite. They follow the tubes. Fasciola is a wrecking ball. When the larva exists in the duodenum, it does not look for the bile duct opening.
It doesn't swim up the duct.
No, it literally eats its way through the wall of the intestine and falls into the peritoneal cavity.
It just punches a hole right in the gut.
Yes. Then it crawls across the peritoneal cavity to the liver. And it doesn't enter through the door, it breaks through the wall. It bores through Glisson's capsule, the fiber surface of the liver, and tunnels directly through the solid liver parenchyma.
That sounds incredibly painful.
It is extremely painful. This is the acute phase. The patient has fever, hepatomegaly, and intense right upper quadrant pain, and the immune system just goes nuclear. You see massive eosinophilia.
Why so much eosinophilia?
Because you have a macroscopic worm migrating through solid tissue, destroying cells, and releasing a ton of antigens. Eosinophils are the body's anti-parasite special forces. They release major basic protein to try and kill the larvae.
So liver rot is the term, right? Necrotic tracts left in the liver.
Exactly. Eventually, after weeks of this, the worm finally finds a bile duct, enters it, and matures. Then the acute symptoms subside, and you get chronic biliary obstruction. But that vial migration phase is unique to Fasciola.
Now, before we get to the treatment, explain the concept of spurious infection, because this is a fascinating false positive.
Yeah, this happens when people eat infected liver. Say you eat a dish made with sheep liver that wasn't cooked thoroughly. Or honestly, even if it was cooked, the eggs inside that liver might remain intact.
Okay.
You digest the liver. The eggs just pass straight through your gut and come out in your stool. You go to the doctor, you get a stool test. The lab sees Fasciola eggs under the microscope. They tell you you have liver flukes.
But you don't. You just ate them.
Correct. You are a transit vehicle, not a host. There's no infection. The way to distinguish this is to have the patient stop eating liver for a few days and then retest. If the eggs disappear, it was spurious.
That is a brilliant clinical pearl. Now, the treatment, and this is probably the single most important pharmacological fact for this entire deep dive.
Yes, it is. Praziquantel does not work on Fasciola hepatica.
Wow.
This is the glaring exception. Almost every other fluke dies when you give praziquantel. Fasciola just laughs at it. The drug of choice here is triclobendazole.
We need a mental anchor for this.
Fasciola is tricky. Tricky starts with TRIC, triclobendazole. If you write praziquantel on the exam for Fasciola, you will get 0 points.
Fasciola is tricky. Got it. Now let's contrast this with the other liver fluke. Subsection B, Clonorchis sinensis, the Chinese little fluke.
Also known as Opisthochus in some regions, depending on exactly which species you're dealing with. This is heavily prevalent in China, Japan, Korea, Vietnam, and the transmission is totally different. It's not plants, it's freshwater fish.
Raw, pickled, smoked, or basically undercooked freshwater fish.
Exactly. Grass carp is a really common
Right.
source. If you eat run meat or raw fish congee, you are ingesting the metacercariae found right in the flesh of the fish.
And the migration, because you called Fasciola the wrecking ball. What is Clonorchis?
Clonorchis is the polite guest. It exists in the duodenum. It finds the ampulla vater, the front door to the bile duct, and it just swims up the duct against the flow of bile. It does not bore through the liver tissue.
So no liver rot, no massive acute necrosis.
Right. The acute phase is often completely asymptomatic or very mild, but Clonorchis plays the long game. These worms are smaller than Fasciola, but you can have thousands of them, and they live for 20 or 30 years.
20 or 30 years inside the bile duct, and that chronic presence is the real problem.
Yes. They cause chronic inflammation of the biliary tree cholangitis. They cause goblet cell hyperplasia, so you get way too much mucus. They cause fibrosis around the ducts. And Murray emphasizes this heavily. Clonorchis sinensis is a class 1 carcinogen. Chronic infection is strongly linked to cholangiocarcinoma, which is bile duct cancer.
Let's break down that mechanism briefly. Why exactly does a worm cause cancer?
It's multifactorial. First, chronic inflammation. The immune system is constantly bombarding the area with reactive oxygen species, ROS, to trip and kill the worm. These ROS inadvertently damage the DNA of the host's own biliary cells.
The collateral damage.
Exactly. Second is cellular turnover. The worm damages cells mechanically, forcing the liver to replicate cells much faster to repair the damage. Faster replication equals more chances for DNA transcription errors. And third, the secretions. The worm secretes proteins like granulin that actually directly stimulate host cell growth. So if you combine DNA damage with hyperstimulated cell growth, you get adenocarcinoma.
That is terrifying. It's just a slow-motion biological disaster.
Let's identify the egg for Clonorchis. It's not the large golden one this time.
No, the Clonorchis egg is very small, and it has two distinct features that show up in literally every visual atlas. First, the shoulders. The operculum, the lid, sits on a rim that protrudes slightly on either side. Looks like the shoulders of a jug.
Okay.
And second, the abopercular knob. At the very bottom, opposite the lid, there's a tiny little comma-shaped knob.
So shoulders and a knob. Visually, it looks like a little electric light bulb.
Exactly. Small light bulb shape with shoulders. That's Clonorchis.
And treatment.
Praziquantel works perfectly fine here. No tricks.
Okay, let's do a quick liver summary. Fasciola is sheep watercress wrecking ball migration and tricky treatment with triclobendazole. Clonorchis is fish polite migration cancer risk and a light bulb egg.
Perfect summary. Moving on. Section 3, the lung fluke. Paragonomus westermani.
This one is an adventurer. It doesn't want to stay in the abdomen, it wants the chest. And transmission involves crustaceans, freshwater crabs, and crayfish.
The drunken crab feast is the classic story for this one, right?
Yes. In parts of Asia, freshwater crabs are soaked in wine or vinegar. People think the alcohol or the acid kills the parasite. It definitely does not. It just makes the crab taste better while the parasite waits. You eat the uncooked crab meat and you ingest the cyst.
Now trace the migration for us because this one is truly impressive.
It starts in the gut, excists, bores through the intestinal wall into the peritoneum, which is similar to Fasciola so far.
Right.
But then it looks up, it finds the diaphragm. It literally bores through the diaphragm muscle layers. It enters the pleural cavity,
Yeah.
and then it burrows straight into the lung parenchyma.
It effectively crosses the border between the abdomen and the thorax. That's a huge journey for a microscopic larva.
It really is. And once it's in the lung, the host encapsulates it. The body builds a thick fibrous wall around the worm to contain it. The worm just lives inside the cystic cavity laying eggs. But the cyst eventually connects to a bronchiole, so when the patient coughs, eggs and blood come up.
And this leads to the TB mimic presentation. This is such a critical clinical mental model.
It's a great imitator of tuberculosis.
Yeah.
Think about it from a diagnostic perspective. You have a patient with a chronic cough hemoptysis, coughing up blood fever and weight loss.
All the classic TB signs.
And when you take a chest x-ray, what do you see? Cavitary lesions and infiltrates in the lungs. It looks exactly like TB.
So how do you actually tell them apart?
Three main things. First, the history. Did they eat raw or undercooked freshwater crabs? Second, the microbiology. The acid-fast bacillus or AFB stain for TB will be completely negative.
And the third?
Blood work.
Yep.
TB causes monocytosis. Parasites cause eosinophilia. If you see a classic TB patient but their CBC shows high eosinophils, you need to stop and think paragonomous.
And there's a very specific sign in the sputum, right? Rusty sputum.
Yes. It's not just bright red fresh blood. It's often a brownish viscous goo. The color comes from the breakdown of lung tissue and hemoglobin, but also from the sheer number of golden brown eggs mixed into the fluid.
Gross, but memorable. Now, because this worm is such an explorer, it sometimes gets lost.
Ectopic paragonomyosis. Ectopic just means out of place. Sometimes they migrate to the skin and form subcutaneous nodules, but the absolute most dangerous destination is the brain.
The brain.
Yeah. If the larvae migrate up the neck or through the soft tissues and accidentally enter the cranium, you get cerebral paragonomyosis. It looks radiologically like a brain tumor or like cysticercosis. The patient gets seizures, visual disturbances, motor deficits.
That is a nightmare scenario. What's the diagnosis for the standard lung infection?
Sputum exam. You're looking for the eggs directly in the spit, though sometimes patients swallow their sputum, especially children, so you might actually find the eggs in the stool too. The egg is operculated golden brown, but the shell is often described as unusually thick or asymmetrical.
And treatment.
Praziquantel. Highly effective here.
Okay, so paragonomous is crab's diaphragm crossing the TD mimic and rusty sputum. Now we arrive at the main event. Section 4. The blood flukes. The schistosomes.
The heavyweights. In terms of global impact, schistosomiasis is second only to malaria among parasitic diseases. We are talking hundreds of millions of people affected.
We mentioned earlier they're the rule breakers, separate sexes, no operculum skin penetration. Let's really dig into the immunology here because this is where the deep dive happens. How do these worms survive in the bloodstream? I mean, the blood is the highway of the immune system. It's constantly patrolled by antibodies, complement neutrophils. How does a worm float around in there for 30 years without getting killed?
It uses a strategy called molecular mimicry. The adult schistosome is basically a master of disguise. It actively absorbs host proteins, blood group antigens, MHC molecules, immunoglobulins, and it coats its entire surface with them.
So it's essentially wearing a mask made of your own skin.
Yes. The immune system bumps into the worm, tastes the surface, says, oh, this is just self, and moves on.
That is incredibly sophisticated. So the adult worm is basically invisible to the immune system. It doesn't cause the inflammation itself.
Exactly. The adults are just chilling, eating blood, and mating. The true villain of schistosomiasis is the egg.
Explain that.
Well, the female lays hundreds to thousands of eggs per day. The biological goal is for the egg to cross the blood vessel wall, get into the lumen of the intestine or the bladder, and be excreted so the life cycle can continue. But about half of those eggs don't make it.
They get stuck.
They get swept away by the blood flow, they get lodged deep in the liver via the portal circulation, or they get trapped in the bladder wall. And the eggs do not have that protective mask. They are highly, highly antigenic. And they secrete proteolytic enzymes to try and melt their way out.
So the immune system sees the trapped egg and just freaks out.
It launches a massive Th2-mediated immune response. It recruits macrophages, the eosinophils, lymphocytes, but they can't kill the eggshell. It's too tough, so they just wall it off. They form a granuloma.
And a granuloma is essentially a ball of immune cells surrounding the foreign object.
Right. And eventually, this granuloma heals with fibrosis scar tissue.
So the actual disease, the liver failure, the bladder issues, is basically the accumulation of thousands and thousands of little scars around trapped eggs.
Exactly. It is fundamentally a disease of immunopathology. Your own body is trying to protect you from the egg, and in doing so, it scars up your liver or your bladder.
Let's look at the clinical timeline for this because it evolves over time. Stage 1 is the entry.
Swimmer's itch, or cercarial dermatitis. When the larvae first penetrate the skin, you get a intensely pruritic papular rash right at the entry site. It's basically a localized allergic reaction to the invader.
And then stage 2 happens a few weeks later.
Katayama syndrome. This is acute schistosomiasis. This happens right when the worms mature and suddenly start laying eggs.
The system gets flooded.
Yes. Suddenly there's a massive release of egg antigens into the blood. The body forms antigen-antibody complexes, immune complexes. These circulate and deposit in tissues all over the body. It's very much a serum sickness-like reaction. High fever chills, urticaria, which is hives, massive lymphadenopathy, and profound eosinophilia.
And then stage 3 is the chronic phase, the fibrosis we just talked about. Now we really need to distinguish the 3 main species of schistosomes. We need an address book and an ID card for each one.
So let's do it. Species 1 is Schistosoma mansoni.
Okay, the address.
It lives in the inferior mesenteric veins. These are the veins that drain the large intestine or the colon.
And the geography?
Africa, the Middle East, and crucially for exams, South America, Brazil, Venezuela, and parts of the Caribbean.
Wait, how did it get to South America if it started in Africa?
The transatlantic slave trade. It was brought over centuries ago, and the right species of snails were already present in the waters there, so it had established itself. If you have a patient from Brazil with schisto, it is almost certainly Manzoni.
Okay, the egg ID for Manzoni.
Large egg, lateral spine. It has a big sharp spike sticking out of the side near the bottom. The mnemonic is lateral for Latin America. It's not perfect, but it really helps distinguish it on tests.
And the specific pathology for Manzoni?
Since it's in the mesenteric veins, the eggs frequently wash back into the liver via the portal vein. You get all those granulomas forming around the portal tracts. This leads to what's called clay pipestem fibrosis, also known as Simmer's fibrosis.
Pipestem fibrosis.
Yeah, the liver parenchyma itself, the actual hepatocytes, often stay functional, so you don't typically see jaundice initially. But the plumbing is completely choked by scar tissue, so you get severe sinusoidal portal hypertension.
Which leads to the big spleen, splenomegaly, and ascites.
And esophageal varices. The patient eventually vomits blood because those varices rupture. That is often the killer.
Okay, so Manzoni is lateral spine, Brazil and Africa, colon veins, and liver fibrosis. Let's look at species 2, Schistosoma japonicum.
The oriental blood fluke. The address here is the superior mesenteric veins which drain the small intestine. Geography is China, the Philippines, Indonesia.
And the egg ID.
It's much rounder, and the spine is tiny, almost invisible. We call it a rudimentary or inconspicuous spine.
Pathology for japonicum.
It's similar to Manzoni with the liver fibrosis and portal hypertension. But japonicum is the aggressive cousin. It produces far more eggs than Manzoni, so the disease progression is faster. And because the eggs are smaller and rounder, they travel much more easily through the vasculature.
Meaning they end up in weird places.
Exactly. They often bypass the liver completely and get to the lungs or the brain. Cerebral schistosomiasis causing severe seizures is most strongly associated with japonicum.
Okay, japonicum is small spine, Asia brain involvement, and severe. Now, species 3, Schistosoma hematobium.
The outlier. The address is totally different. It does not live in the mesenteric veins. It lives in the vesical plexus, the network of veins surrounding the bladder. Geography is Africa and the Middle East, especially the Nile Valley in Egypt.
The egg ID.
Terminal spine. The spike is right at the very tip of the oval. The mnemonic here is hematobium has a terminal spine.
And because of where it lives, the pathology is totally urinary.
Yes. The eggs have to bore through the muscular bladder wall to get into the urine. This causes massive physical trauma and bleeding. Hematuria blood in the urine is the absolute hallmark. In heavily endemic areas, it's historically been so common that boys thought it was just a natural sign of puberty.
Wow. And the chronic accumulation of eggs in the bladder wall.
It leads to 3 things. 1, fibrosis of the bladder, making it stiff and non-compliant. 2, obstruction of the ureters, backing up urine and causing kidney damage or hydronephrosis. And 3, cancer.
This is the big exam question right here.
Yes. Squamous cell carcinoma of the bladder. Normally, the bladder lining is transitional epithelium, or urothelium, but chronic irritation from the eggs causes metaplasia. The tissue turns into squamous epithelium just to protect itself from the trauma, and eventually that squamous tissue becomes malignant.
So schisto equals squamous cell cancer. That's a huge distinction because standard bladder cancer in the U.S. is usually transitional cell.
Exactly.
What's the diagnosis for the schistosomes generally?
You check the output, stool samples for Manzoni and japonicum, urine samples for hematobium. You're looking directly for the eggs. There are also rapid antigen tests checking for circulating cathodic antigen, or CCA, which is great for Manzoni. And serology is really useful for travelers who might be infected but aren't shedding eggs yet.
And treatment.
Praziquantel, it works wonderfully on the adult worms of all 3 species, though it's worth noting it doesn't kill the eggs or the very immature migrating forms effectively, so sometimes you actually have to repeat the treatment a few weeks later to catch the ones that grew up.
We've covered the big 4 groups. Just briefly before we wrap, let's touch on swimmer's itch one more time, just to differentiate it from true systemic schistosomiasis.
Right, cercarial dermatitis. This happens when bird or mammal schistosomes, species that normally infect ducks or raccoons, try to penetrate human skin by mistake.
They get confused.
They do, they get in, but the biochemical lock and key just doesn't fit, so they die right there in the dermis. The human immune system attacks the dead larvae, causing intense itching and hives. But they never enter the blood. They never get to the liver or the bladder.
So itchy skin, yes. Systemic disease, no. It's a dead end for them and just an annoyance for us.
Exactly.
All right. This has been a massive download. We've covered a ton of biology. Let's do a rapid recap of the host pathogen chess match before we hit the recall question.
Okay, intestine is Fasciolopsis buski. Giant Asian fluke, pigs, water chestnuts.
Liver has two. Fasciola is sheep watercress, violent migration, high eosinophils, and you must use triclobendazole. Clonorchis is fish polite migration cholangiocarcinoma and the light bulb egg.
Lung is perigonymous. Crab's diaphragm crossing the TB mimic and rusty sputum.
And finally, blood is the schistosomes, skin penetration, separate sexes, and molecular mimicry. Mansoni is lateral spine, America's pipestem liver fibrosis, Japonicum is small spine Asia and brain involvement, Hematobium is terminal spine bladder and squamous cell cancer.
Excellent summary.
One final thought before the quiz. We talked about the snail imperative early on. In many ways, the best way to control these diseases isn't actually just developing better drugs. It's snail control, molluscicides, or introducing ecological predators like river prawns that naturally eat the snails.
It's the very definition of a neglected tropical disease. It requires infrastructure sanitation and ecological management to truly solve. You can treat the patient, but if they walk right back into the water with the infected snails, the whole cycle just starts again.
And think about the evolutionary brilliance of that masking technique the schistosomes use. Why haven't we developed a vaccine yet? Probably because the parasite knows our immune system better than we do.
It's a sobering thought.
All right, let's see if these concepts actually stuck. It's time for learning reinforcement. I'm going to throw out 5 rapid-fire clinical scenarios. I want you, the listener, to shout out the answer or, think it really loudly before our expert reveals it.
Let's do it.
Question 1. A 45-year-old sheep farmer presents with fever and right upper quadrant pain. A CT scan shows hypodense tracts in the liver. Stool microscopy reveals large operculated eggs. You prescribe praziquantel, but the patient does not improve. What is the organism and what drug should you have used? Pause.
The organism is Fasciola hepatica. The huge clues are sheep farmer and tracts in the liver indicating that violent migration. It is naturally resistant to praziquantel. You should have used triclobendazole. For consolidation, you should review Murray's section on Fasciola hepatica treatment.
Question 2. A patient originally from Egypt presents with painless hematuria. Urine cytology shows atypical squamous cells. Which trematode is most likely responsible for this malignancy? Pause.
Schistosoma hematobium. It inhabits the bladder plexus, and chronic irritation leads to squamous cell carcinoma. Remember, hematuria equals hematobium. Review Murray's section on Schistosoma hematobium clinical syndromes.
Question 3. A man returning from a trip to Thailand presents with a chronic cough and brownish sputum. His chest x-ray mimics tuberculosis. He admits to eating drunken crab at a local festival. What would you expect to see on a sputum wet mount? Pause.
You would see operculated golden brown eggs of Paragonymous westermanni. That brown sputum is rusty due to the thousands of eggs. Review Murray's Paragonymous westermanni epidemiology.
Question 4. You are looking at a stool sample from a patient with portal hypertension and esophageal varices. You see an egg with a prominent lateral spine. What is the likely geographic origin of this specific infection? Pause.
This is Schistosoma mansoni. The geography could be Africa, but uniquely it could be South America, like Brazil or the Caribbean. Lateral equals Latin America. Review Murray's Schistosoma mansoni diagnosis.
Question 5. Which liver fluke is associated with the consumption of raw freshwater fish and is a known class 1 carcinogen causing cholangiocarcinoma? Pause.
Clonorchis sinensis or Opus thorcus. The key is the fish vector and the direct link to bile duct cancer. Review Murray's Clonorchis sinensis clinical syndromes.
And a bonus mechanism question. Question 6. Why do schistosome eggs cause massive granulomas, but the adult worms floating in the same blood vessels do not? Pause.
Because adult worms use molecular mimicry, coating themselves in host proteins to evade detection. Eggs do not have this mask and are highly antigenic, triggering a massive Th2 granulomatous response.
If you nailed those, you are absolutely ready for the wards and the boards. If not, Chapter 75 is waiting for you.
And seriously, don't ignore the snails.
Thanks for diving deep with us today. We'll see you in the next deep dive.
See you next time.